Hi everyone, today we're going to be talking to you guys about outpatient physical therapy for our Peer Teaching and Learning in Traditional Settings project. The U.S. Code of Law has provided us with this definition of outpatient physical therapy services. Please take the time to read it. Outpatient physical therapy is also known as private practice. The three boxes are the categories of settings. You can have hospital-based with local examples below it, private practice, which could be PT-owned or physician-owned, and examples of each in our area, and lastly, specialized areas, with examples below. In reality, there is quite a bit of overlap between these categories. Please keep that in mind moving forward.
The first thing that a therapist and outpatient might ask is how to even begin the process. I found an article on WebPT that explained the necessary resources and steps to take in order to begin. First, the therapist must become fully credentialed in order for insurance companies to provide full reimbursement. This just means that we have to pass our NPTE board exams and obtain our license and NPI, which is basically a HIPAA-mandated identifier for all healthcare providers. We then have to have a clinic location, which can be owned by a private hospital or specialized clinic mentioned earlier in the lecture. Physical therapists also have to maintain malpractice insurance in order to practice. After all of this is finished, a therapist can begin to form contracts with various insurance companies to be considered in-network. Keep in mind that being in network with certain insurance companies can also act as a marketing tool, especially if you're working in a small privately owned clinic.
When it comes to billing, a lot of providers use billing software to prepare and submit their claims. If you are thinking about starting your own outpatient physical therapy clinic or are curious about what kind of billing software you may come across, I included some examples and what they include. The smart ones use an electronic medical record system that includes or integrates with the top-notch therapy billing software, such as Hello, WebPT, and Therabill. That way they eliminate double data entry as well as the errors associated with it. If you go this route, be sure your solution is fully HIPAA compliant. You'll also want to be sure to select a solution that offers the following key features and benefits listed below. Cash-based clinics also need to use billing softwares, so just so you know. And I also included a website that will allow you to research other reputable billing softwares so that you can review and compare them so that you find the perfect one for you.
So typically in the outpatient settings, especially the larger ones, the therapists perform the treatments and provide the codes to the billing department. The billing department then does a lot of behind-the-scenes work with the use of the previously mentioned billing softwares. Before the therapist ever sees the patient, the billing department must call the company with patient identifying information and make sure that they have insurance prior to performing any interventions. After the treatment is performed by the PT, the billing department bills it to the payer, which we know can be the patient, the insurance, or a combination of the two. Keep in mind that there are many types of medical codes, but we care specifically about CPT codes for intervention in the billing process. Most of these are going to be in the 9700 series, which is called Physical Medicine and Rehabilitation. ICD-10 codes are PT diagnoses. A provider can bill any code as long as the provider can legally render that service according to state licensure laws. This means that we have to keep watch over what we are billing and the services that we are providing and make sure that we are legally allowed to participate in that service in our state.
As previously explained, when billing for services provided by us as physical therapists, it is necessary to use CPT-4 codes to describe the services that were performed and provides a reasonable framework for billing. As you can see, those CPT codes most relevant to rehab therapists, especially outpatient physical therapists, are located in the 9700 section. I highlighted some of the most common codes that us as physical therapists would use in an outpatient clinic, such as modalities, aquatic therapy, gait training, NMR, TheraX, manual therapy techniques, therapeutic activity. There are also codes for evaluations and reevaluations, but I'll explain those later. I also provided a link below for more commonly used codes if anyone else is interested in accessing that. In addition to understanding CPT codes, it is essential for us as physical therapists to understand CPT codes for initial evaluations and the evaluation complexities before billing for services. The correct documentation of complexity is important because it can be used to make future value determinations while reflecting the expertise, skill, and responsibility of physical therapists in caring for their patients and clients. Complexity factors are influenced by patient history, results from examinations, and standardized tests performed, patient presentation, and time spent with the patient and/or family. It is important to be familiar with the codes and to use them correctly because the Centers for Medicare and Medicaid Services are still exploring whether and how to incorporate striated payment into the tiered CPT codes for the 3 levels of complexity. So it's important to understand whether they're low complexity, moderate complexity, high complexity, so that you can accurately bill for them. The following links will hopefully clear up any questions or comments about the CPT codes for the evaluations and the evaluation complexity in case you have any.
It is the responsibility of a licensed therapist to keep up with policy and CPT changes for proper documentation and reimbursement. In my experiences in the outpatient setting, the director of the clinic watched these changes closely and reminded the staff of changes via email, sticky notes, posted bulletins, and verbally. These are a few examples of CPT codes that have changed in 2020 according to Medicare reimbursement policies, which are essentially followed by most other private health insurance companies. The codes for dry needling were changed to specify the number of muscles that were punctured. However, CMS still does not consider these always or sometimes services, and therefore we will still not reimburse for dry needling. On the other hand, both biofeedback and cognitive function intervention codes were added to the list of sometimes therapy services, according to the CMS, and will now be reimbursed.
There are rules as to how we can bill patients in an outpatient setting. I'll be discussing mostly about Medicare, though private insurances also have its own regulations. The Medicare administrative contractor, which is designated to each region, so in Texas it's called Novita, they're the ones responsible for interpreting the regulations and applying them in each state. And we also have to know that Medicare has its own rules for each part A, B, C, and D. For example, if you wanted to do co-treatments, they are limited to 2 disciplines during one therapy session. We also want to make sure that there's proper documentation on our end, one so that we get reimbursed, and for future purposes, if we get a lawsuit, we want to make sure that we had proper documentation. We also want to follow state regulations. So for example, if the state does not allow dry needling, don't do it. Private practices are more susceptible to take corrective actions under HIPAA regulations because they don't have to follow as many rules compared to hospitals, and these clinics also don't have to be JCAHO accredited. There are penalties for violating HIPAA rules, such as getting fines or getting imprisoned, and it is important to report if there has been a HIPAA violation or breach. We also have to consider that HIPAA rules apply in the telehealth system. There are various ways to be HIPAA compliant. First of all, you want to make sure that you use an electronic medical record that's HIPAA compliant. You want to secure passwords, encrypt and back up your data, install antivirus programs. When it comes to emailing your patients, you want to make sure that they consented to it. Also, if the patient were to take a device home that were to record anything about them, such as heart rate or blood pressure, that needs to be a HIPAA compliant device. For example, Fitbit is a HIPAA compliant device.
Outpatient settings operate with a fee-for-service type of payment system. This essentially means that you are paid based on the amount of services you provide, and the more services you provide, the more you get paid. So even though outpatient is volume-based rather than value-based, outpatient settings are being encouraged to join merit-based incentive programs if they reach certain requirements. And if patients are making progress, the clinic may be eligible for a 9% pay increase. However, if they fail to show improvement in their patients, they may be subject to a 9% penalty or no increase at all. Outpatient settings face unique challenges with regards to reimbursement, including cancellations, difficulty collecting co-payments from patients, and claims rejections and claims denials from insurance companies. So claims rejections are generally a result of simple clerical errors that can result in the claim not even being processed by the insurance company. They can be corrected quickly and then resubmitted. An example of this type would be an incorrect patient ID number. Claims denials are a little bit different. They have some of the correct information, so they are still processed by the insurance company, but not paid on. These can also be a result of clerical errors, but they might also involve documentation issues. New grad PTs tend to experience more claim rejections because of a failure to document medical necessity or demonstrate skilled care. So I'm going to go more into depth on some strategies to avoid these two common mistakes. The APTA and CMS have different definitions of medical necessity. However, although the APTA is more strict and specific than Medicare, they are overall pretty similar in that they both require safe, necessary, effective care that requires the knowledge and skill of a physical therapist. So even if you receive a referral from a physician, you still need to justify medical necessity in your documentation. The APTA has some basic guidelines in documenting medical necessity, including providing a brief assessment of the patient's response to intervention after every single visit, documenting their clinical decision-making process. For example, you need to explain why you change the patient's exercise program, or add or discontinue a modality, or progress a functional activity. You also have to make sure documentation is not repetitive or just restating the same thing after every visit. And they also recommend rereading your own documentation so there's no doubt that only a skilled physical therapist could have provided the treatment. So specifically with regards to patient evals, you want to relay a comprehensive patient history. So you're going to want to include all relevant medical and psychosocial events that could influence their recovery, as well as providing a detailed account comparing their current and previous functional ability. And this could involve meticulous chart review as well as a really good subjective history taking. The second issue that new PTs tend to run into is in the outpatient setting is failing to demonstrate skilled care. So the excerpt on the top of the slide here is from a Medicare claims denial, and it lists exactly what Medicare is looking for and their requirements for reimbursement. And this includes clearly communicating what you measured, analyzed, adjusted, fabricated, adapted, facilitated, and educated, and proving that it was at a level that required your skills and expertise. So to provide some examples of skilled versus unskilled care, we have on the left unskilled care, and on the right it's saying the exact same thing. It's the same exercise, but it would be interpreted as skilled care. So on the left here it says patient ambulated 50 feet with a wheeled walker and minimal assistance. And on the right, it says minimal assistance to ambulate 50 feet with front wheeled walker, required manual facilitation to stabilize right pelvis hip during stance phase, and verbal cueing for right toe clearance during swing phase for safe forward mobility on level surfaces. So this example would be considered skilled because it mentions manual facilitation and assistance during specific phases of gait, as well as verbal cueing. So the second example, it has on the left step downs 10 repetitions, and on the right it says control descent from 6-inch step standing on right lower extremity 10 reps with verbal cueing for alignment of hip, knee, and ankle. So the example on the right would be considered skilled care because it mentions verbal cueing to maintain correct body alignment. So the third example is very similar. It says mini trampoline landings times 10 reps. And again, they mention verbal cueing, but they also mention a modification due to patient response to therapy. So both of those things would make this example skilled care. The last thing I'm going to cover is what to do if you do get a claims denial. So first of all, it's best to appeal a claims denial early. Some sources say within 7 days of the insurance company's final decision, and you'll have a much higher chance of the claim actually being paid on. The numbers they used were 67% if you appeal the claim within a week, and then it drops down to 40% if you wait after a week. Another good thing to know is the APTA is a really good resource for different templates that you can use for appeals, like the example we have right here on the right. You can just download those and then fill in patient information. And they have several different types of appeal templates, but this one is just the general one for medical necessity.
So by now you probably know what payer mix is, but a simple definition I found is payer mix is healthcare jargon for the percentage of revenue coming from private insurance versus government insurance versus self-paying individuals. We can't talk about every type of outpatient setting, so I broke it down between hospital-based, privately owned, and specialized areas and the type of payer mix each deals with. So starting with hospital-based, insurance companies and self-pay patients compensate hospitals at a higher rate than government programs. Government programs typically pay less than the actual cost of patient treatment, leading to hospitals losing revenue. This is why many hospitals rely on self-pay and private insurance. Moving to privately owned, they have a wide variety of just self-pay, private insurance, or government, or a mixture of any of the three in order to pay them. And lastly, for specialized areas, it's pretty much the same as privately owned. It just kind of depends on the location where they are being accessed. This graph is a lot to take in at first, but basically is showing different annual gross revenue ranges and the percentage of how many clinics are in that revenue range. Then it further splits it up comparing different types of payer mixes. For example, this graph shows that 68% of cash-based only clinics make less than $100,000 of gross revenue a year.
So we found a good overview of PT responsibilities on the APTA website. Some of these responsibilities include interpretation of referrals, of course, evaluation, PT diagnosis and prognosis, development or modification of a plan of care, PT goals and outcomes, determining whether a PT can see this patient or if the patient is appropriate candidates to be seen by a PTA, revision of the plan of care, conclusion of an episode of care, and they are responsible for any handoff communication. They are of course responsible for documenting the services given to each patient. Supervision in PTAs in an outpatient setting. Medicare says that to bill for outpatient services provided by a PTA, the following conditions must be met. The services the PTA provides are medically necessary. The supervising therapist provides direct on-site supervision, even if they're not in the same room. The supervising therapist has active, ongoing involvement in the management and control of the patient's condition. The PTA is an employee of the practice. Student physical therapists, when participating as part of a physical therapist's professional education, are only qualified to provide services under the direct supervision of the PT who is responsible for the patient and client management. The APTA recommends that students do not document directly in the chart.
So earlier this year in January, PT in Motion made a list of hot issues for 2020, and that includes direct access, dry needling, physical therapy compact, fair copays, imaging, utilization management, Practice Act updates, and telehealth. So real quick, I'm going to mention the highlighted ones. I thought they were pretty interesting.
direct access. All states have some form of direct access, but unfortunately, some direct access in states are more limited than others, and they impose restraints as referral requirements and visit limitations for specific interventions. Fair copays, so insurance does not take into account that patients require multiple visits for physical therapy, and they make copays pretty high for patients, and it makes it harder for patients to come to see us due to high cost per visit. And then lastly, telehealth. With everything going on with COVID-19, the push for telehealth right now, especially with Medicare reimbursement, is a pretty hot topic. So APTA has a page strictly designated for COVID-19 and telehealth. It's just giving updates of day-to-day changes with COVID-19 and telehealth. As of right now, since March 27, APTA joined AOTA and ASHA to expand Medicare coverages for telehealth services for the COVID-19. And the services include audiology, occupational therapy, physical therapy, and speech language pathology. You can click on the links below for more information or go to the APTA website.
Outpatient PTs can exhibit leadership by keeping up with their APTA membership, advocating for outpatient physical therapy and the profession as a whole, run for office, become a CI to teach future DPTs about outpatient PT, become a clinic owner, participate in pro bono and volunteer work, take continuing education courses to keep up their skills and learn the best evidence out there, complete the LAMP Leadership and Professional Development course series offered by the APTA, and develop and maintain professional interprofessional collaboration with physicians, OT, and other health professions. Most importantly is that patients look to outpatient PTs as leaders or experts in their field. Please see the speaker notes below for resources for advocacy involvement opportunities and ways to take action. A leader at the national level is Dr. Heidi Janenga, who was a multi-clinic site director at an orthopedic outpatient facility before becoming a co-founder of WebPT. A leader at the state level is Dr. Michael Gilhode, who specializes in orthopedics and manual therapy and is president of the TPTA. Another leader is Dr. Harvey Eichmann, who is the owner of the Ortho Sports Outpatient Clinic and is on the Executive Council of PT and OT Examiners. A local leader whom we have met is Dr. Rachel Herbeck. She graduated from TWU and specializes in geriatric PT. She gives lectures at the TPTA, APTA, CSM, as well as at TWU, striving to improve the care of older adults. In fact, she was our guest lecturer in Dr. Shirley's professional practice class. So this picture is of us with her in the top left corner after she taught us how aging is not a disease. Finally, the private practice section of the APTA is a great place to find resources for anything outpatient PT related. Please see the speaker notes below and click on the link for more information.